right, class. We're going into another drug. This one's kind of one of our staple cardiac drugs, and it is a great drug for what it is used for. And we're going to talk about that very specifically. And we're talking about, of course, adenosine. And then kind of as a joke, make it go, make it stop, make it go, make it stop. It's such a very true statement. But there's some things about adenosine that you truly need to know and need to understand about adenosine before we get into why it works and how it works. So again, this is Adenocard is the other big name for it. If you're going to remember the C10H13N504, I doubt that very seriously. But again, adenosine, it is a naturally occurring drug actually within our system. It's used to treat supraventricular tachycardia, and again, it's used for the cardiac rhythm disturbances. And what it is used is for narrow, complex tachycardia. And I have to stress that in a huge statement there. So again, it's a class 1A antiarrhythmic drug. It actually naturally occurs within our body. Okay, so it's what it does is it slows or interrupts the reentry pathways through the AV node, and it slows the conduction through both the AV node and the SA node. It blocks supraventricular tissue, so it actually stops that tissue. It blocks potassium channels, and then therefore it slows down the conduction of the heart rate. So again, it slows the conduction through the AV node pathway. So basically what it does is and if you watch this, when you give this drug on the cardiac monitor, you're going to see a brief period of asystole, maybe a little bit of ventricular ectopy in there as it begins to wear off. This drug, its onset of action is immediate, and but it literally is out of your system in 30 seconds or less. The half-life is only about 10 seconds. So you have to get this drug to the heart to get it to do what we need it to do. And we'll talk about that when we actually administer the drug. So we use it for supraventricular tachycardia. That or paroxysmal, meaning it comes, it goes, it comes, it goes. And then it's refractory to vagal maneuvers, okay? This is referred to as chemical cardioversion, okay? And so, again, it makes your heart stop, all right? So, again, some of the side effects you're going to get from this drug. When you stop somebody's heart, they're going to know it. Matter of fact, one of the biggest problems you're going to have is if you got somebody with known supraventricular tachycardia, and they've had adenosine before, and you go to give them adenosine again, they're probably going to tell you no. And they're going to probably say use cardizem. And, by the way, listen to them. Because if they've had this happen before, again, they usually don't like the sensation of adenosine. But what does adenosine do? Well, the biggest thing is when it stops the heart, you get all these other things. The headache, the blurred vision, the dizziness, the facial flushing. Okay, it's going to cause a warm sensation for them. They're going to get a very bad metallic taste in their mouth. These are very common things that I've seen when I've given. For some reason, I always got stuck in the zone with a bunch of supraventricular tachycardia patients, and I would wear out some adenosine on those. But these were the common things. Now, this can also cause heart blocks, which is that's a problem. And usually what happens is that the ventricles, once they kind of reset, they kind of go, wait, we got to go to beating. So you're going to see some PVCs as they come out of the adenosine, the asystole phase of the medication. Again, they're going to get very kind of nauseous, actually, and they get that metallic taste in their mouth. And again, the heaviness in the arms and the neck and the pressure in the groin is probably due to the lack of blood flow, that brief period where you'd have absolutely no cardiac output. So, when do we not use adenosine? If they have a second or third degree heart block, if they have sick sinus syndrome. So what sick sinus is where it kind of turns on, it goes crazy, goes fast, goes slow. And it all happens in a matter of maybe 2 to 3 minutes. It's when there's a dysfunction of the sinoatrial node. If they're in an aflutter or afib, there is a irritable foci, or it's just quivering. The heart, adenosine is not going to do anything for them. Remember, it works primarily through the AV nodal pathways is how it stops it. If they are in true ventricular tachycardia, again, we run a 12 lead, and we have every indication that this is ventricular tachycardia. Adenosine really doesn't work for them. Now, this is where everybody kind of gets lost about using adenosine, okay? Every now and then you're going to get a patient who's got a bundle branch block or a wide block, and they're going to, it's actually a supraventricular in origin, but because they've got a wider complex due to the left or right bundle branch block, they're going to have some problems, all right? So again, if it's true ventricular tachycardia and we converse it. Poison-induced tachycardias, by the way, if I drink 5 Red Bulls and then I try to fix it with adenosine, it's not going to work. Remember, adenosine electrically resets the heart. But if you've got a bunch of caffeine in there or amphetamine or cocaine, it's not going to stop that from reoccurring, okay? So we use it when we think that there is an electrical problem of the heart. If they have a tachycardia because they're septic and they got a heart rate of 160 and it's a narrow complex tachycardia, you haven't fixed the problem. So as soon as you give the drug, they're going to go right back into it because you didn't fix the problem, okay? And it's so very important to state that, especially when we're dealing with narrow complex tachycardias, you got to fix the underlying problem. This drug fixes an electrical abnormality of the heart, okay? So again, if they are on theophylline drugs and caffeine, they bind to the receptor site, so you're probably going to need a bigger dose of adenocard. Diphenhydramol, it potentiates the effect. Smaller doses may be effective. So if you see that they're on persantine, you might want to back off. Usually the 6 will do just fine. Guys, with that being said, remember, this drug's out of your system in 30 seconds. With persantine, it might even hang around for 35, 40 seconds. But again, nothing that we can't recover from. So again, it's a safe drug pretty much to give these patients. Again, if they're on Tegretol, it's a seizure medication. If they are on that, you can have them develop a high-degree block, a second or a third-degree block with that. And one of the other problems that we get with given adenosine is you're going to get them to wheeze, okay? So bronchoconstriction can happen, especially if you got an asthmatic patient. They'll start wheezing on you. All right. So again, when you're given adenosine, we push the print button, all right? We let it print, and we push the adenosine so we've got a complete and total record of what happened, all right? You need to warn the patients, this is what's going to happen. You're going to feel that metallic taste in your mouth. Everything's going to get heavy. You're going to get some chest pain, all right? You might get a little bit dizzy. You might get a little bit weak. We're stopping your heart for about 5-10 seconds. So again, and it can produce, again, asystole or heart blocks. It can produce those, so just be aware of that. The asystole, I promise you, goes away. It's usually no longer than 15 seconds at the very most. But while you're sitting there looking at it, it feels like, a half a day. So you need to push this med closest to the heart. So if I've got a central line, that's the way I want to give it. If I've got a small vein in my hand, I would probably look for something bigger, maybe an external jugular or something higher up on the arm, okay? Guys, a small dose is all you need for if you got a transplant patient. Remember, it works very quickly on these guys. And again, watch out for the wheezing because patients that are asthmatic or they have disease process already, actually, to throw that in there a little bit, if they're wheezing due to the COVID issues, it can also cause problems there. 6 to 12 milligrams is what we're going to use. 6 milligrams in a 2 milliliter vial, then 12 milligrams in a 4 liter. Don't dilute it, but when you do give it, what you're going to do is give it over 1 to 3 seconds. When I say IV slam, this is the one you push in fast, okay? And then rapid saline flush behind it, 10 to 20 milliliters, okay? I put them both in the same port. If I don't have that, I take a 3-way stopcock, and I push the drug, and then I push the flush. The old wise tale of just hang the bag up real high and squeeze it. Again, no, I want to push it, because if I don't get it to the heart within 10 seconds, it doesn't work. And by the way, when you see that on the monitor, you should see that drastic slowdown. Drastic, if not going into a systole, okay? And then they're going to have maybe a couple PVCs, and then they'll usually come back out either into normal sinus or whatever the rhythm was. Now, the cool thing is during that slowdown period is when we can usually tell whether they're an AFib or a flutter, in which case we can adjust our treatment appropriately. Now, after we give the first dose and it didn't work, by the way, if you give the dose and I don't see any of that slowdown, it didn't get there. Repeat it, okay? But again, usually we repeat with this 12 milligram dose, all right? And again, if I still didn't see the pause, I didn't give it right, so let's do it again, all right? And, well, what happens if they don't get affected by it? Trust me, if it gets to the heart, it's going to affect it. All right. Pediatric dose is, again, 0.1 milligrams per kilogram up to 6, and then you double that up. You can go up to 12 on your second dose. All right? But use your breathing space tape on that. All right? And IV means IV, okay? That means you push it fast, you push the flush right behind it, okay? Then you hang the IV bag up and squeeze it, okay? And the reason that I say it like this is because don't just use that, I'm going to squish it with the IV bag to make it work. No, it's got to have a solid flush, at least 20 cc's behind it to make it work. I have actually got the unfortunate, had to use this on a pregnant patient. There was no ill side effects that I know of. It can cross the placental barrier, though, and it may cause fetal damage. But again, when you got a heart rate of 240 on a patient, it was a really crazy situation. So that's where we're at. Again, adenosine, so it's a great drug to use, but again, you remember about you gotta push it fast, you gotta push a chaser behind it, and again, you need to see that slow down, that asystolic period. All right, we'll see you on the next one.